welcome to On Becoming a Healer. I'm Stefan with my co-host, Saul Weiner. Hi, Saul.
Hey, Stefan.
I know that today you wanted us to actually read through a transcript of an actual primary care visit between a doctor and a patient. What do you have in mind and why are we doing it?
So, Stefan, I've had this weird disconnect over many years between what I hear during audio recordings between doctors and patients, which is what I study, and the way in which I see it taught in a somewhat idealized way, particularly with medical students. As you know, for many years, my team has been doing research in which we hand out audio recorders to patients to record their visits with their doctors. Most of these are done incognito so that the physician is not aware at the time that they're being recorded, although it's an approved protocol. And so we have these incredibly authentic recordings but by authentic, I mean there's sort of no Hawthorne effect. The physician is just being themselves, and the patient is doing what they do. And then I contrast that with when I've looked at how communication is typically taught. As you know, there are all these acronyms. There's PEARLs, and there's SPIKEs, and there's LEARNs, and there's ARTs. Well, PEARLs is probably the best known of them, and that stands for partnering with the patient, conveying empathy, apologizing for any errors, showing respect, legitimizing the patient's feelings, and showing that you are supporting them in managing their challenges.
Okay.
And what I found when I actually listened to these encounters, and the one I picked is a sort of typical encounter between a medical resident and a patient, is that there's just a chasm between the way in which it's taught and the way in which it's practiced. Now, that isn't to say that what the resident is doing is, quote, bad. In fact, it sounds kind of typical. And when I listen to it, I'm like, that could have been me. But it raises many questions, I guess I would say, about what an encounter is really like, whether that's what we actually want. And it's opened for me the idea that maybe when we're teaching doctor-patient communication, rather than starting with sort of the ideal, we should do the opposite. We should actually start by listening to how doctors and patients really sound, and then talking about what we like and what we don't like, and giving the learner, in this case, perhaps a medical student or resident, opportunity to reflect on that, rather than kind of teaching it in some kind of vacuum. So the idea today is just to actually work through a transcript. I have a small team that audio records these and listens to them. I asked one of my team leads to just basically pick a transcript that is typical. I said, don't pick something terrible, don't pick something fantastic, just pick the usual. And that's what we really want to work through today. I should also say that this transcript has been fully de-identified and is approved for this type of exercise. I have some other good news, which is that we're going to be posting over 400 of these transcripts on a public website, again, with full approval to do so. So they'll serve as a resource for learners and teachers who actually want to start from this perspective of listening to what actually happens during the doctor-patient encounter.
Well, we're about to read this, but I do want to highlight, somebody's going to say, oh, it's a resident and a patient. We don't think residents necessarily know what to do. But I believe that this resident is not much different from fully trained doctors you've heard. Is that right, Saul?
Yeah, no, our audio coders listen to everything. They listen to residents, medical students, attending physicians. This is an experienced resident. Nothing magical happens between PGY 3 year and becoming a primary care doctor the next. Our communication habits are set in quite significantly during those training years. And so, so I think that we could have picked somebody at a different point in the trajectory. Kind of a senior resident is a probably pretty typical place to center it.
And having read ahead, I will confess I've had more than a few visits that sound a little too much like this one for my own comfort. But I'm happy to play the doctor in this particular transcript.
Yeah, and that makes me the patient. I will pause at various points to kind of reflect on what we've just heard.
Okay, so let's begin scene. How are you?
Pretty good so far.
I'm Dr. Jameson. What brings you in today?
Oh, I had an appointment.
Anything bothering you today?
Yeah.
What's that?
Knees. My knees.
Your knees? What's wrong with your knees?
Well, one of them had to be replaced. This one here is it's been doing what it's doing. I mean, it's slipping out of place voluntarily.
Oh, one of them was replaced, so now you just have a lot of arthritis?
Yeah, I got bad feet.
What have you been taking for the pain?
Tylenol.
Tylenol with gabapentin?
Uh, haven't had any.
You haven't had any? You have refills. Why don't you get it refilled?
I didn't know I had to. I didn't even know I had refills. I probably misplaced it.
Or okay, your knees are just a regular arthritis pain. You're able to walk okay?
No, I can't do prolonged standing.
Has
No.
it been getting worse recently or just the same old?
Ah, this one's getting worse.
It's getting worse. Do you think it needs to be replaced?
I've been trying to avoid it, but
You haven't had your knees x-rayed in a couple of years. We might want to get that redone today. Everything else okay today? Do you need any refills on medicines other than the ones we discussed? Okay, let's take a pause there. Let's ask, what's going on here?
so I mean, I think as we can see, the visit gets right down to business. The doctor's clicking away at their computer. I think you did a good job with that, Stefan,
Yeah, I
actually.
tried to do that.
And so there's several things that have happened so far. We learn that the patient's confused about how to get their refills, that he's struggling with knee arthritis. He's been considering a second knee replacement, but he's fearful of it, presumably because of some experiences he had the first time. And the physician is essentially just trying to stay on their tasks of getting through a whole bunch of stuff, and just says something like, "Let's do another test," and then sort of moves on to the next topic.
Yeah, I mean, at playing the role of physician here, there were moments where reading the script, I thought, huh, I think that you're supposed to do that. So you're able to walk okay. I was like, you're able to walk okay. Like, that's a functional assessment, right? I think that you're supposed to do that. But somehow the sum of it or the whole of it felt like less than the sum of its parts. And I kept thinking, I don't really understand who this patient is. I kind of have a sense they missed some pills. It all kind of felt a little shallow.
I mean, yeah, I mean, we don't even know the patient's name, and that's not something we removed from this. The patient has not been named by the doctor. We don't know anything about their life or who they are yet, who's there to support them or help them in any way. The patient's clearly struggling. They're kind of confused about some things. That's kind of being glossed over. The physician is sort of just task focused. They're just moving forward. They're pleasant. The physician's perfectly pleasant. They're clearly trying to, quote, do their job. But, when I look at, quote, pearls, is
Oh
there a
yeah. So what was
partnership
the pearls?
occurring? I don't.
Probably not.
I wouldn't think of it as a partnership, a conveying of empathy. Well, I mean, I haven't seen an
No,
acknowledgement,
I mean
yeah, of
the doctor's kind of like quickly trying to figure out what happened, what needs to be done, or there's this interpretive statement very early. One of them was replaced, so now you just have a lot of arthritis. Like,
yeah. I mean, I
what's
think
that? Is that a
I
diagnosis?
think the thing that you did well is I think the doctor is looking at the computer screen, and they're clearly trying to get through stuff. You almost seem like you can imagine them having like an old note open or something, and they're kind of going through it. Maybe the last assessment and plan or problem list from the last person, and they're just boom, 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 and yeah, that's kind of what it feels like to me.
We could bet that the doctor doesn't really know the patient. Like, this isn't someone they've seen before.
No,
They're just trying to catch up. Should we try the second part?
yeah,
It ended with me saying, "Do you need refills on other medicines?" Then that's what I said. Do
yeah.
you need
My
refills?
Dilantin and my
Dilantin and your hydrochlorothiazide
yeah, yes, yes.
and your Tylenol.
Yeah, because I haven't had any of that in a long time.
What's your Dilantin dose? 100 milligrams. You do 2 tablets in the morning and 2 tablets in the evening.
Right.
Okay, good. Your blood pressure's okay today. A little high.
I I know why. I think it's these socks, these tight
Oh.
socks. See the way they're cutting. See the way they're cutting out the circulation here.
Now, have you seen the neurologist recently? Because they weren't supposed to change your dose
They did.
because they want you to be 300, not 400, right? Did you make that change?
No, they put me on. Last time I was here, they put me on 2 in the morning and 2 in the evening.
Who did? The neurologist?
The doctor that I saw.
In urgent care?
Yeah, because I came in. I had a seizure.
Yeah, you need to see neurology. You haven't seen them. It's been too long. Let me see when you're due to see them next. Yeah, you don't even have another appointment, but you need to see the neurologist. You didn't go? Okay, let's pause there.
All right.
I think I just heard the patient had a seizure. Oh my
Right.
God.
Yes.
Okay.
So
So,
yeah.
um, don't you agree, Saul, that if the patient says that they had a seizure, they do need to see a neurologist, right?
I do. And I think the thing that's interesting about this is, most of what you would just read is, a doctor talking about pill dosages for blood pressure, pain, seizures. It's essentially a kind of medication
Yeah,
reconciliation.
I'm tracking the meds, and it's getting a little overwhelming. This has happened to me, by the way. This is not unique to this doctor. I've literally been there. Like, wait, what dose? What did he get it? Where did they go? Where did they get? Why do I have to? Don't I have to know when they got it? And I'm getting confused. So I'm working through the Dilantin or phenytoin, and I'm working through the hydrochlorothiazide, and who changed the dose? And boom, right in the middle of it, he says something about a seizure, and I've kind of not got a lot of bandwidth for it, to be honest.
Yeah, no, I,
So
I noticed that. There are little things that pop up. So, for instance, along the way, the patient indicates that he thinks his tight socks are causing his high blood pressure, and the doctor's just like, "Huh," and it just kind of keeps moving on about with that. Right? And there is a certain pattern of just like not really talking to the patient about things they're confused about. It's just sort of like there's not a lot of teaching going on, and par for the course. Rather than asking about the seizure when it kind of pops up out of nowhere, the doctor just starts emphasizing, oh, then you really need to see this specialist, and starts focusing on why the patient hasn't seen the specialist already. But there's no comment on like, well, what the heck happened with the seizure? Tell me about that. That just, it's just more of a like, oh my God, you need to see a neurologist.
yeah, it's a 2 for 1 for the doctor because I'm still lost on the medications, and particularly who changed the GABA. Was it Dilantin? Yeah, who changed the Dilantin or the gabapentin? And I'm trying to figure out where are the meds getting prescribed. Yeah, it's Dilantin actually, 2 in the morning and 2 in the evening. And then he says seizure. So I guess I was working on Dilantin because he has seizures. He says he had a seizure. I don't, at one level, if I could just get them to neurology, I don't even know when this was or where it was or what kind it was, except the problem is, I mean, as a real doctor, I sort of do need to know those things. So there's this real discomfort with, I want to get rid of this issue so I can get through the chart and get through the visit. And there's a part of me that's thinking, this is terrible. Like, you really do need to know when people tell you they had a seizure, what the heck happened? And there's no space for that in this visit.
Yeah, I mean, it's, and again, we've listened to a lot of encounters between primary care physicians and patients, and we hear a lot of this sort of triage mentality of just sort of the doc going through their list of stuff and then, okay, we'll send you to this specialist, or okay, we'll send you to that specialist. And again, we're seeing that here as well.
And not to be too harsh on this doctor, I have been there. So the patient is giving me a narrative that I know I'm supposed to figure out on the pills and the prescriptions. And in the middle of it, they tuck in a complaint. And there is part of me that is like, oof, why did you have to do that? I now have to, either I have to clarify and move forward, or I need to just stop and listen to what actually happened. And it's a discipline moment where I imagine I've done it both ways, but ideally I should stop and say, you had a seizure. Huh. Okay. Let me hear about it. Like that's really what should happen.
Right.
What would have happened if I'd done that? I guess you would have explained something about how it happened.
I think what's so interesting about this typical visit is both in the ways that it feels so normal and understandable, and in other ways how it seems so lacking. If you sort of step back and get over the extent to which we've normalized this way of interacting with patients because it's something we're also familiar with, and just say, wait a minute, we have no idea who this person is. We have no idea, are they having, like, what's the deal with these seizures? Are they at risk of having them at home? Is there anybody there? Has it ever happened? Are they,
Could it have been not a seizure?
Maybe it wasn't even a seizure. Like what is happening here? Just that kind of narrow focus on the next task, which is to get this person a consult or something. I think it's, on the one hand, it's so normal. And if you think about this in a larger sense as two human beings in a room, and one is trying to be helpful to the other, and of course, the one who's trying to be helpful is hopefully a highly trained healthcare professional, you would ideally be looking for, and a human, you'd be looking for a different kind of encounter, different types of conversation. And then someone else might say, well, we don't have time for that. So I think
Yeah.
it's an
It's a
interesting.
5-minute visit,
Yeah,
Saul.
exactly. Yeah, it's not really 5 minutes, as you'll see. It's a longer visit than that. But often we say, "Oh, we don't have time for that."
Let's try the next part.
All right. So here we go.
Okay, so I just so people know, I said you need to see the neurologist. You didn't go?
I didn't have an appointment yet.
You don't even have one scheduled. Have you had any other seizures?
Uh, None since then. No, I I felt one coming, but I stopped it. I took the medicine right quick.
Okay, so you never saw.
I haven't been to neurology yet. He mentioned scheduling me for an MRI.
Yeah, but the thing is, you never you need to see the neurologist. Did you ever get the MRI done?
No, they didn't schedule yet.
But you got the EEG.
Uh-huh.
Did you ever see the podiatrist, the foot doctor?
No, no,
Oh yeah, you did in August. Let's see.
but not since then though.
Oh, okay. Did you have the colonoscopy?
No, I chickened out.
You chickened out. You didn't want it then?
I I didn't want it. No, I mean the whole idea just threw me backwards. I guess if I get up enough courage whenever they schedule me for one again, I might get up enough courage to do it. I don't know.
Okay. And you take simvastatin? No.
No.
You don't take anything for your cholesterol?
I was taking something, but they discontinued it.
Why?
That's what I'd like to know.
LDL 80. Oh, wow. It looks like you may not need one. And you need your blood pressure medication?
Oh yeah,
Okay.
and my Dilan. I only have 4 capsules left.
Okay.
I know what brought on that other seizure, though.
It brought on seizures?
No. I say I know what brought it on.
What did?
I had a sort of earth-shattering event.
Huh?
I had a sort of earth-shattering event.
Oh, what happened?
Um, well, my youngest daughter, she's 35 years old, and she called me up from home and told me that she'd been diagnosed with MS.
Oh, I'm sorry.
Yeah, it threw me upside down, and I
So you were taking the medicine. It wasn't that you weren't taking it.
yeah I was taking the medicine, but that
So then you just had another, like a big emotional event.
yeah I had a it threw me off. It threw me way off.
So you have access to the medication, though.
Yeah,
It's never been a problem for you to get it.
no.
Okay.
No problem. Some things, it starts up with an anxiety attack. You get this sick feeling in the stomach with the anxiety attack.
Yeah.
You start feeling cartwheels with different colors. And if I don't take medicine right away, it gets me blind temporarily.
Oh no.
And then comes the seizure. The whole left side just trembles out of control. And I'm standing.
Now your right leg, you have some infection on it. What's cueing the doctor to suddenly talk about the right leg and an infection here at the end of this incredible interlude where we've heard about a massive family catastrophe? We've heard about the initiation of a seizure. The doctor seems aware that there's something traumatic because the words "oh no" are used. And then suddenly it's right leg. I have to guess the doctor has suddenly seen something in the medical record about the right leg having been treated. I don't know because there's nothing in the text of this exchange which suggests the patient introduced the right leg.
I mean, I agree. I think there's something else that needs to be said too, which is the fact that the physician changes the subject after this patient has made multiple attempts to talk about this trauma. Um,
Yeah,
to
and
me, implies
anxiety.
one of several things. One is implies that the physician who's thinking the sort of task completion mindset has already decided that they know what they need to do about that one. They just need to get them to neurology. It's like, done with that. I don't need to talk about all this other stuff because whatever is going on, they just need to see neurology. And that's one possibility. The other possibility is the physician just isn't comfortable going into the emotional issues or the struggles of this patient and just wants to move to a different topic. There are many possibilities as to why this physician just keeps on trucking. And the next thing, as you point out, is a complete non sequitur.
Right leg.
This whole section is filled with non sequiturs. First, it's a podiatrist, then it's the colonoscopy, then it's the simvastatin, then it's the dilantin dosing. And again, when they're talking about the colonoscopy, where the patient talks about their fear and their anxiety and the fact that they might be willing to have it anyway, boom, they're on to simvastatin. And it doesn't even seem like the colonoscopy got ordered. So it's that mindset that I think is most notable here.
Yeah, there's a lot missed. And I think after we read the next section, I'm going to talk about the problems of this kind of visit when you are the attending in the back room who hears about these cases. But I want us to read the next section before we come back to that. Is that all right, Saul?
Yeah. So yeah, just pick up on the
So
last
I'm going to
thing
pick up
there.
with the right leg, which
Mhm.
admittedly the patient didn't mention, but I say, now your right leg, you have some infection on it.
Yeah.
Is that all taken care of? All done?
Yeah. I mean, I had
Can I see it? You need some lotion.
yeah, I got some lotion. I just didn't use it this morning.
Okay, I'll be back in a second. Okay, I need to check with the attending.
Uh-huh.
So we know from this that there's a 7-minute absence,
Yep.
and I return and I say, okay, all right, you need to see the neurologist.
When's that?
I want you to go up to the front and make an appointment right now before you go.
All right.
And I want to get some labs. I want to get some labs done today. Will you go to the laboratory before you leave?
Oh, you mean like a blood draw?
Yeah.
So I go make the appointment
Yeah.
for the
So,
neurologist right now?
yeah, yeah. They'll make it for you right up front. Okay. And then I want you to come back and to see me in 1 month because then I want to see what the neurologist says. You need your medications refilled?
Yeah, yeah, I do.
I'll meet you up there. Okay. I'm going to get your medications done and then I'll meet you up there and find out when the appointment is.
Okay.
And then you have to go to the lab.
I I go to the lab and then can I go home?
Then you can go home.
Okay.
But I'll meet you up there in the front in just a minute. Okay.
Okay.
That's the end of that. So, one of the things that struck me in reading this is that we seem to have jumped out of the right leg problem into I'm going to the attending. Oh, a lotion, a recommendation of lotion, and then I'm going to go. Like, I'm done. But then there's this thing that happens at the end where at the end of the visit, I'm very nervous that the elements of the plan that we laid out are going to get bungled as the patient is leaving. And so there is a way in which all the coaching by the doctor about getting to the appointment and I'm going to come out there and make sure that you got the appointment is kind of caring, right? Is it caring?
Yeah,
Isn't it caring?
it reflects that intense conscientiousness that so many of us are fortunately programmed to do.
So I think one part of me just says, okay, let's give this doctor some credit. I've been reading this visit. We're kind of not sure it's a really great visit, but it's hard to argue that the doctor doesn't want to, quote, do the right thing.
I think one of the things about presenting this case is we can sort of throw it back to those who are listening to think about what is gained in this visit and what is missing in terms of the kind of interaction that's occurred. And I
Okay.
think what's gained, what's there, as you pointed out, is that certain tasks are highly pursued, namely, getting the refills, getting the patient scheduled for, a certain critical appointment. And the resident is right in that both of those things are important. And then I think on the other side of the ledger, we have to ask what is missing. And what I would say is essentially everything else. And so, we learn nothing about how or whether this patient is coping with their situation. Is there anyone helping them? Is there anyone in their life? Does he live alone? What's happening with his daughter who has multiple sclerosis? There's no real relationship formed between the doctor and the patient, as far as I can tell. And the patient, as you said, is sort of placidly accepting of this. When he tries to repeatedly share his suffering and his shock, and his anxiety, she just keeps moving on to other topics. And he just, he goes along with it. Substantively, it strikes me that she kind of just blows past all of these issues, whether it's, his anxiety about having a colonoscopy, the question of whether he's actually having seizures, or is this some sort of anxiety reaction? These certainly don't seem like generalized seizures, considering the patient describes himself as being, awake and on his feet when they occur. So that sort of is intriguing. You might want to find a little bit more about what's happening there. And where does pearls fit into this, right? So if you kind of go back to the
Oh, yeah.
model.
Pearls. It's partnership with the patient, conveying empathy, apologizing for any errors, showing respect, legitimizing the patient's feelings, and showing that you are supporting them in managing any challenges. So that's pearls. Is it happening?
Yeah, and so if we try to score the doctor in each of these, how would we score them? Is there a partnership? What would you say?
Personally, I would say it's kind of a low medium partnership. There's something about meds that's really going to happen here. Some med is going to get picked up, some labs are going to get done, but I don't know that the patient would walk out feeling that their doctor was a partner to them.
Okay, conveying of empathy.
That's a great question. Saying "oh no" or "I'm sorry" is considered a kind of conveying of empathy, I think, but I don't think that there is much understanding of what this man is going through.
And what about respect?
Ooh, that's a hard one, Saul. I don't know what to say. What would you say?
Well, I think that's the point. I think what's interesting is we learn these acronyms like pearls, but what do we really mean? Like what constitutes showing another person respect? I think that term can be used in a wide range of ways. So at a very minimum, this doctor was not overtly disrespectful. They weren't
No,
overtly
they weren't rude.
disrespectful, but at the same time, there wasn't a sense of acknowledging or seeing the full humanity of their patient, which to
No.
me would be really the most I would say, rich meaning of the concept or word meaning of respect.
But there's all these situations where we'll say people are treated with respect, like you get on an airplane and there's a flight attendant who says, "Welcome to the flight." I would say I was treated with respect just because they said, "Welcome to the flight."
Absolutely. But there's a difference between being a passenger on a flight and where the person who's a flight attendant is basically greeting a whole bunch of people who are basically well and want to get on their iPads or watch movies or maybe get some peanuts, and somebody who is coming into a doctor's office with a whole range of medical needs and potentially a
Ugh,
crisis, like an adult child who's become seriously ill. And so I think
ugh.
the expectation for what respect would mean in those two situations is different. And I think what's interesting is
Hmm.
not just the question of do we need to tell medical students that they have to have this acronym and remember to be respectful, but then the question of is what does that really mean? And I think that when I listen to the audio of this encounter that we role played, the doctor has a kind of kind quality. There's nothing rude about it. You get a little bit of a sense as if they sound like they're talking to somebody who's a bit of a child, not in a insulting way, but just that's kind of, the way you often hear people talk to quote old people, the way you sometimes hear that
Yeah.
kind of tone of voice. So that is it's not overtly disrespectful, and
No.
there's nothing in the patient's response that conveys that he's felt
No.
disrespected. Exactly. So it's normalized. It's normalized for many of us who listen to these, and it's normalized probably for the patient because this is what they're used to. But if we ask a larger question about what it means to be a physician and what it means to see someone in their full humanity, what would that look like? What could this visit have been like if it had been that? I
Well,
think that to me is really the question.
I mean, just to take so I have so many mixed reactions to this, but let's start with the answer to your question. What would it have looked like if it had been that? At a minimum, I would have heard key moments of inflection and stopped typing, and particularly that moment of she's diagnosed with MS. I think even in some of my not great visits, I probably would stop, look over, and say, "Huh, she's been diagnosed with MS. Tell me about that. Tell me what is happening." And I would also ask, tell me what you think is going to happen for you as you go through this. Because what I'm curious to make a human connection, but I'm not just trying to be nice. I'm actually trying to figure out, is a whole pile of crap going to land on my patient's head because he has to assume responsibilities that his youngest daughter can't assume at this time? And those are all going to influence the medical plan. So yeah, I now want to know what it means for his daughter to have MS because I'm trying to figure out if the entire plan for all of the things we discussed today might have to change. So it's not just being nice.
I agree. I think that I actually don't have a problem with a visit beginning in a fairly task focused way if that's what the patient wants. So you come in, and of course, I think that the patient should be acknowledged by name. That doesn't happen here. But I think that it's fine to say, anything bothering you today, or what can I do for you today? That's a perfect way to begin. You're giving the patient an opportunity to do that. But I think what's striking is what happens after that. And imagine if instead of the physician feeling a need to just get through this list of stuff and what's so interesting about these things is some of them are very important and others are quite trivial, and it's almost as if that doesn't matter. The physician has their to-do list. So the fact that the patient is having seizures, well, we heard about that, but now we need to figure out whether they need lotion or whether they need to see a podiatrist or whatever it is. So I think that ability to turn away from this is my to-do list and say, I'm gonna be open to going where this visit goes, and we're gonna focus on the priorities. And I'm gonna start to relate to this person as a full human being. And when they start talking about their struggles and their fears and the fact that their daughter, I'm gonna immediately be thinking, like, what would I do how would I react if this were my friend or my neighbor? I'd want to know, well, who's in your life? Who's helping you with this? What's going on? Like, if you think about this from a humanistic standpoint, I would think that you would open your heart as you would with any person outside of this bizarre kind of doctor patient transactional situation and start to try to figure out, like, how are they coping? How are they managing? And that would be a sort of natural way for one person who cares to respond to another person in this situation. And I think that to me is what the other version of this visit could look like. And what's troubling to me is that that's something that we've not only lost, but we've even lost the imagination to imagine.
I think I agree, but I want to talk about how we teach residents, medical students, and how then we in turn, as quote grown-up physicians or whatever you want to call us, are graded. I precept in a clinic. So in an academic clinic, a resident comes back to a room and describes the case and certain information that they collected. And very often it's problem based. They review a set of problems and a set of solutions. And things like for the diabetes, they got this medicine. For the seizures, they apparently were about to run out of Dilantin. There were some seizures recently. There was an emotional shock, but I got them on the meds. We're going to get labs checked today. Like residents present a series of problems and a series of solutions, and I say, sounds good. And most of the time when I'm listening to this, I am basically asking, does the problem that was presented to me as summarized by a medical resident correspond to the solution? And then the second thing I ask is, there's a standard checklist of things that I've expected to have done, which is rather long, by the way. And I'll be like, oh, did they cover the checklist? And Frank, residents surprise me with how much of a checklist they can cover. I don't think I could cover as much as the residents I teach cover. So
And the
I,
question, of course, is that good or bad?
I mean, I'm in a system that grades the residents on whether they presented problems that match the solutions. And I'm in a system that assesses in some ways whether the checklist was covered. And I guess they're doing what we're teaching them to do.
Yeah, I think it's an incredibly important point. I think the problem is that we're a product of the same system they are. And then think about the system that we're a product of. It's one that's centered obviously around billing, around note generation, around hitting a series of requirements for, say, I don't know, a level 4 visit, whatever it is. It's this idea that we can't miss anything, that we have to cover all the territory. And so it really becomes all about us.
It's all about us.
It's all about us. Yeah, it's all about us and the system that we are a cog in. It's the system that we are a cog in. That's the dirty secret. And it's become so normalized. And yet, if we were just there in a room with a person and trying to figure out how can we be most helpful to this person given what they're dealing with right now, how would this visit be different? We might not even get to the colonoscopy. We might not get to the talking about the simvastatin and whether they need it. We'd have a patient who we're concerned about because they've got some weird seizure thing going on. They obviously need to see a neurologist, but that's just the tip of the iceberg. We need to know, how are they coping? What risks does this pose to them? Are they alone at home? Is it affecting them and their ability to function? Do we need to get them any help? Who's in their life? And it seems to me that if you saw this encounter as just an opportunity to try to be helpful to someone, all of that would be evident, that you would want to know that, just out of a need to get a picture of who this person is, what they're coping with, and what you need to do to help them.
Okay, so hypothetically, if a resident heard that this patient's somehow falling apart and having things that feel like anxiety or seizures because they are under incredible stress because their daughter has just developed multiple sclerosis, and they gave over the entire visit to understand the implications of multiple sclerosis, and maybe didn't follow up on the foot or the recent leg infection, or didn't actually iron out whether there is or is not going to be a colonoscopy, there would be a lot of checklist items that are not done on this visit.
That's
And
right.
in the healthcare record system, depending which record system you're looking with, this resident they might look worse as a doctor than the one who covers the checklist, right?
Absolutely. So a couple thoughts about that. First of all, any individual visit is not likely to be the 1 in 100 or 1 in 1,000 that get an audit. So I think that that's a little bit overblown.
Okay.
I think that obviously if you're attending, in this case it's a resident, is a stickler because they've been indoctrinated with this efficient task completer mindset to the nth degree, you're going to be stuck with that, right? If that's who you're going out to see. And we don't know who this resident is going out to see. But setting aside those two, if we just sort of focus on the fact that, first of all, this is what we hear over and over again, and we've listened to over 10,000 encounters.
10,000?
Yeah, over 10,000, our team, over the number of years.
This is not, just to reassure people, this is not some sort of weirdo visit. This is a typical one.
Yeah, we've been listening to these
10,000 or so.
Yeah, we've been listening. We've been recording visits. And there were years when we were recording over 1,000 a year. And some of you know we've published extensively on that, including a book on the topic. So anyway, so the point is that this mindset has kind of taken over healthcare to a very substantial degree. It's not the only thing we hear, but it's a big, typical sort of middle of the curve type of thing. And the question we need to ask if we're trying to train the next generation of doctors is, how do we deal with this? And I think we have to deal with it by starting by talking about it and listening to it and being open about it. And what's interesting to me when I listen and look at how medical education communication is taught, and I've been to a number of medical schools,
Yeah.
it's done almost in the opposite way. It's done with sort of like these acronyms, which kind of teach you these ideal frameworks. And then when you start to even look at them, I don't even find them necessarily that helpful because, as we said, like, what does it mean to check off the respect item on the checklist? What does it mean to check off the empathy? Because they just become, kind of buzzwords in a way. And so I think that, and also they're taught in a bit of a vacuum outside of the culture. And the culture is this sort of mindset that we're talking about. And so I think that's a disconnect that I experience when I hear these and then when I go and see how
Yeah.
doctor-patient communication is being taught.
So you mentioned that these transcripts are about to be posted, not all, the ones that are officially cleared, anonymized, protected in all respects. Those anonymous transcripts are going to be posted publicly. Is that meant to be a resource for educators?
Yeah, we'll be posting. I'll put a link in the show notes so that people can access those transcripts. You also see there's a spreadsheet where we have coded all of them for contextualization of care, which is not the topic of today's
Sure.
podcast, but if some of you know from other episodes, that's been the focus of my research and the reason that we've been doing this audio recording for so many years. And the particular set of transcripts that we're sharing have been, as I said, vetted and approved and de-identified for posting for educational and research purposes.
Because I think it could be really helpful if both educators, not just in medicine, but in other health professions, and learners actually look at a transcript like this and say, without being unduly critical of the doctor, but like, what would you wish you could have done if you were in the room at this time? And what do we wish we'd like to have happen to us if we were the patient in the room at this time? That could be a great conversation, and it might actually lead us to a different place than where we are now.
Yeah, I think the other thing that I find helpful to talk about is the relationship between the power dynamic in the room
Yes, let's
and the
get to
way they
that.
communicate. And so this was, again, this was a low power patient, is just the way I would describe it. This was a patient who had clearly had a much lower level of education than the physician and was somewhat passive. For example, if you listen to just the last section that we were reading, the way in which the physician is talking to the patient is pretty directive. They're saying, all right, you need to see the neurologist. And then they say, I want you to go up to the front and make an appointment right now. And then they say, I want you to get some labs done today. And then they say, so go make the appointment with the neurologist right now. It goes on. And then at some point, the patient says almost plaintively, then can I go home?
Like,
And
can I get
the
out of
doctor
here?
says, and then the doctor says, then you can go home. Okay. So I think it's striking. And again, having heard this recording, what strikes me is that the doctor comes across remarkably sympathetically, despite all of this.
Yeah,
They come across as trying to be sweet.
yeah,
And it's not like it's some horrible interaction. They are, and then again, as you can see, they're very conscientious about the couple of things they want to do with this visit. So I think it's important to talk about the way in which these power dynamics play a major role, because you can only experience a sense of shared humanity with another person if you do it on a level playing field. I think it's a very important principle. And so as long as you're seeing that person in some subtle way as beneath you, and I hate to use that term, but that's what it is, you are going to talk down to them. We hear this all the time. We hear this in sort of nursing homes where the patient is being talked down to, often in a very sweet way. Now, then the question becomes, who do you look down on? So if you're in the room with a person who is homeless and smells bad, you could either look down on that person and talk down to them because they're poorly educated, they can't follow what you're talking about, and you're going to fall into this kind of efficient task completer mindset, or you might genuinely see this individual in their full humanity. Now, how does that happen? It happens if you understand that, but for the grace of God go I, that this
Hmm.
person
Oh, you
was
sound like a
born into
lefty
it.
now.
They had a different deck of cards than I did. I
Ah,
have no idea whether they're smarter or less smart than me. What I know is I won the lottery in terms of the world in which I was born to, the education I got to have, the color of my skin, and so forth. And this individual, well, they kind of lost the lottery. They certainly got a lower number than I did, a much lower number. And yet, I have no idea how to live out on the streets. This person has all
hmm.
kinds of savvy I don't have. I don't know what they're thinking of me. And so if you can see that, then you realize that you're no better than the person who smells bad and who doesn't seem to know what some of the fancy terminology you've learned mean. And if that happens, then you begin to relate to them with that full sense of caring and humanity. You start to form a connection with them. And one thing that happens is you start to build trust. And I think one thing that we didn't talk about in this encounter is the extent to which that opportunity to develop a relationship and to develop trust is you're never given a chance.
Yeah, yeah.
We don't know what this patient is thinking when they walk out. We don't know if they're going to show up again. Why would they? I mean, they'll probably go to that neurology appointment, we hope, but that doctor gave them very little to look forward to. There was no acknowledgement of their suffering other than that, oh my, or I'm so sorry. And so that patient got very little out of that in terms of being seen and felt and experienced as a human. And without that, what ties those two people together other than this sort of transaction, which results in a consult being placed and some medications being refilled?
So I want to highlight that there are two things that really struck me here. One is about whether this patient is likely to come back, and the second is whether politics or political philosophy should be guiding our response here. So I think we have some evidence from prior literature, and my own team is in the process of writing up data that the nature of how patients rate their experiences with their clinician and whether they feel respected and things like that actually influences their likelihood of establishing continuity of care and returning for another visit with the same person. So if you were entirely mercenary about this and saying, for me to do effective primary care, I need to see people more than once, it appears that an authentic connection is part of making that happen. So that's a material argument that I think
Absolutely.
supports what you said. Now, when you also said something which is sort of there, but for the grace of God, go I. And I actually remember writing a newspaper column as a high schooler of that very nature, speaking about people being dealt a deck of cards. And what I learned over time is that I'm a lefty. I see things in that light, and it makes sense and is resonant to me that I relate to people with this idea that it could have happened to me. I guess there could be people who want to be effective doctors who are actually have a different political philosophy. And I guess, are they out of this conversation, or should we, I mean, do we need to wrestle with what it means if they think, look, people who are doing
It's
better
interesting.
merit it, they earned it.
Yeah, it's interesting because I actually think that the political philosophy and how that person truly interacts with somebody of, quote, lower class in a weird way doesn't actually sync. So, for instance, there are a lot of people who might call themselves liberals and who kind of wear that as a badge, who actually, when they're with a patient of a lower class, treat them like they're of a lower class.
Hmm.
They just do it anyway. In other words, they talk the talk, but they don't actually, it hasn't been internalized. It's become an identity badge, but it isn't who they actually
Yeah.
are. And which, by the way, I think is what breeds a lot of cynicism about people who are, quote, liberals or even progressives, that they're like, well, you say all that stuff, but quite honestly, that's not what we're experiencing when we're around you. We're experiencing that we're being patronized. And I would say the same thing
Yeah.
about someone who describes themselves as conservative. I would say their philosophy may be more based on like, well, I got to where I am because of merit, and those people are lazy. That concerns me because I would say that if you genuinely believe that, I would be concerned that you're more likely to actually treat people like that. But I wouldn't say necessarily that that's going to happen because also I think people are indoctrinated with their badge. I can see somebody who wears their conservativeness as a badge in the same way, but when they're at the scene of a car accident and they go
They're
there,
just a human being.
they're a human being and they
Yeah.
give their heart and soul to helping somebody
Yeah.
who looks completely different from them. So I would say that it's not a one-to-one
No.
correlation or even close.
Yeah. By the way, that is my life experience. I have never looked for data on this, but I have the same basic experiences you described. So I think I've really felt like this is an incredibly interesting dialogue to entertain and to play out as a transcript, not because it's unique, but because it's typical. And in my own mind, I am resolving to both listen to patients a little bit differently, but specifically also to teach in a different way as well. And I'm going to explicitly target this issue the next time I am sitting with medical residents or students and they're getting ready to present. I'm going to say, look, I'm aware there's a checklist issue that often comes up in these kinds of visits. But what I also really want to understand is if you got to understand the situation that this patient's facing, because I think it's likely to have real impact on the type of relationship you form and the care we can deliver over time. And I'm hopeful that we'll discuss that.
Yes, I think your points are well taken. And what I would add to that is if you're a medical educator and you're training the next generation of physicians, consider beginning with talking about what really happens during an encounter. If you decide to use these acronyms, be mindful of their limitations, not just in the way in which they can be a distraction from forming real relationships, but also how vague they are and how difficult it can be to interpret what each of those acronyms stands for and what it means to respect, which, by the way, can also become a teaching moment. So if you are going to go through pearls, why not have a conversation about, would this count as respect? Would this count as partnership? That becomes an opportunity for reflection with a young physician or a future physician as well. So anyway, thanks, Stefan, for walking me through this transcript, for doing a great job playing the physician. And I hope this resource will be useful and helpful to our listeners.
Thanks, Saul. Just remember, before you go, you need to go to the lab to get your blood drawn, okay?
Don't patronize me.
Take care.
We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.